It's very obvious because we have a lot of very interesting biomarkers in the Alzheimer's space. Very good biomarkers, very high performing biomarkers, but they either require pretty complex imaging approaches, and one that comes to mind immediately is of course amyloid PET, where you have various radio tracers. It's a pretty complex, expensive infrastructure to manufacture and distribute those ligands. And then obviously they have short half-lives and the patient has to be scheduled to come in time, and it's just an enormous cost and complexity around PET imaging. The other one we have is primarily based from CSF samples. It's generally considered to be what we call invasive because you need a needle. It depends on the operator, etc. And sometimes you have slight side effects of this, headaches, etc. So obviously people like something that's even more simple and very commonly accepted. And something that people never complain about, although it's a needle involved, you can say it's invasive as well, is of course a blood sample. People are so used to do it, and anyone can do that in a medical practice. So we would like to have something simple that gives the same information or very similar information than what we get from the imaging methodologies or sampling from the cerebrospinal fluid.
From the clinical trial perspective, as a clinical trialist, we know that if you take a look at the enormous amount of effort we have made in the clinical trial space, and we look at such a high failure rate of clinical trials, I think a lot of them can also be attributed to the fact it's difficult to recruit patients. And why? Because that there has been very high screen fail, and because we rely on the amyloid as part of the screening tool in order to qualify the trial participant to determine if they are eligible or not for clinical trial. And I think it's very expensive and it's very difficult. So therefore, if we have a blood test as a pre-screening tool, that would allow us to really reach out to mass population, to rapidly screen the patient and to bring them to the clinical trial in a much more cost-effective way. I think by having a validated, sensitive blood test on board, that will help us save time, save cost, and then we can rapidly accelerate overall clinical trial development processes and allow us, the entire industry and healthcare professional, to bring the new treatment to our patients.
It's an interesting and unique technology. It's based on magnetic beads coated with an antibody that bind the target protein, and then the beads are made to oscillate or spin, and that can be measured very accurately and with very high sensitivity. So in that way it's a unique technique, and also with very low background, which allows the very high sensitivity to measure very small amounts.
I'd love to say that my colleague, Dr. Bleno, kind of put it in the best state of mind. Until recently, the idea of discovering or detecting plasma was almost impossible until the technologies have improved. The elegance and sophistication of these technologies are so good. It's equivalent of trying to find a pebble in a swimming pool. That's how much they have become that sensitive in their detection technologies. IMR technology is such that they can detect tau levels into the picogram level, which is just amazing, and we couldn't do that before.
First of all, for the clinical trials, it would be great to have a screening biomarker. and that is easy to take and easy to apply, even out in primary care or at the place the doctor who meets the patient first works. And based on the results of such a screening test, the patient can even be assured that nothing is wrong or admitted for more detailed investigation at the specialist clinic. So I see that as the main application, screening.
I see it used in clinical trials, particularly in prevention. Prevention trials, you know, we're scanning a lot of people particularly because we think they're going to get the disease, and then we're having to scan anywhere between 4 to 1 to 10 to 1. So on the throughput, on the clinical trials perspective, is clearly would be useful, so that you don't have to be doing all these scans and other tests. That's number one. But clinical practice, number two is, you know, right now we do a B12 and a TSH and we check a few other things, and imagine if you did an IMR, you know, this MagQ technology, and it becomes part of a diagnostic blood test package to check you for Alzheimer's changes, like we do for rheumatology, like we do for infectious diseases. I mean, we bundle all kinds of blood tests, and that's a common practice. So this could become useful as a screening measure to determine if there's more need for other tests.
We have several projects. They're longitudinal projects, so people coming in and have annual assessments, and they range from people who are cognitively normal to people who have very mild subjective memory complaints to people who have mild, moderate, and severe memory disorders. And so one of the projects we're trying to do is to try to determine what is the best way to detect people at risk for dementia who live in the community. So community-based samples as opposed to people who self-select and come to a hospital or for care. And the other project we have is a prevention project. So can we use the profile that someone has by their individual biomarkers and create an intervention for them that can reduce their risk of developing Alzheimer's disease. These blood-based biomarkers are going to be critical to not only stratifying people to the right group, but be able to follow them over time to see if they're responding to therapy in a way that's changing their risk.